Michelle.
No,
It's nice to see you.
I have a new game. I'm so excited.
Oh, no, I'm excited. Let's see. We have here on Zoom with us Marcia. I'm glad you're here. You're gonna like some news, Marcia. We have Rena and we have Angela. Yay! Hi, ladies. Okay, that's my dog barking. Yep, yep, just a little barking. Just a little. He'll probably stop in a second. When one dog barks, they all bark. It never fails, I swear. How are you guys doing tonight before we start streaming? How are you guys doing tonight? Hopefully good. Let me make sure we're all set up. Awesome. Okay, cool. Well, it looks like we're already live. So welcome into the 3-day EKG challenge, night 3. Okay, so this is where we're going to bring it home. Let me go ahead and hit record to make sure we have the recording.
Recording in progress.
And if you're just watching us on Facebook, go ahead and say hi. And if you're on Zoom, we've already said hi, but we love it if you can come on Zoom and we can chat with you more and see how you're doing. But anyway, Michelle, my co-host is with the most, is here tonight. And you're going to love it because she's going to kick us off with a game. So Michelle, are you able to share?
Yes, I think so. I tried it before. Yes, it should be working. Okay. And let's put that on. Play from start. Okay, I have a new one. We haven't done this one before. So we'll have to see how it goes, if we like it or not. If we don't like it, we just chunk it. It's not a big deal. So if anybody is in the chat and they want to pick a number, so this is just pick a number, just type a little number in there, and we'll just go on chat for, oh, good, somebody said 4. Thank you. Okay, so we're going to go on my chat all the way so I can see. Okay, so we're going to go on 4, and this is inverted T waves. Inverted T waves. So now you get to pick another number and see if you get what matches that. So either somebody on Facebook, if they are there, or somebody in the chat, just pick another number. And let me see where I hid the answer to that one. So it's kind of like a cross between matching and Jeopardy. I just kind of made this game up. So, but type in another number and see if you want to pick something else. Just type it on in. Or I will pick and show you what the first, oh, here we go. Okay, somebody picked. Okay, Angela, perfect. Okay, so this one is name that rhythm. So neither one of those match yet. So pick another number and let's see if we can get any of these to match. Go ahead and pick another number. So this is just picking numbers, guys. Okay, oh, we got one. All right, oops. Okay, it's a trick of the finger here. I want to make sure I got, okay, there we go. All right, so number 2 and number 4 do match because the inverted T waves are something to do with AVR and V1. So in AVR and V1, they have to be inverted. They have to be inverted for it to be normal. Okay, so pick another number and let's see how this goes. We got 2. Go ahead and just type in a number. I'm watching on both sides, just anything that's left. This is just for fun, just a quick little, a new one. Okay, number 1. Okay, so, oh, we have an EKG. Let's see if you find anything else. Now, that doesn't match up with the rhythm. Oh, 6. Okay, good. Okay, oh, we've got a lot going on here. Oh, we haven't made another match yet. So that question is leads 2, 3. I'm supposed to see AVF. Sorry, it looks like my picture went over the word. Leads 2, 3, and AVF are from the same artery. What would be another word for that? Okay, pick another number. Pick another number. I'm making y'all work for this tonight. Okay, 3. Let's see. LAD, left circ, and RCA. Oh, no matches yet. Pick another number. Pick another number. Anybody on Facebook? We've got 3, 11. Okay, let's see what's in 11. Oh, contiguous leads. Okay, so contiguous leads, number 11, matches up with number 6. So the word contiguous I like to call them sister leads because I like to say that leads 2, 3, and AVF are just like triplets, and they all look at the same coronary artery. That same coronary artery, the RCA goes, whoa, I am down here at the bottom of the heart, that inferior wall, and I am looking, when my leads are on, I'm looking at 2, 3, and AVF, and they're called contiguous or sister leads. Okay, pick another number. We have matched up almost everything now. Keep going. Pick another number. Okay, number 5. Let's see what we have under number 5. The P wave, the PR interval, QRS, and T wave. Nothing matches that on there yet. So pick another number. We're almost done. We only have 4 more. 7. Okay, number 7. Number 7 says, I got to move my chat all the way here. Name my arteries. Good. All right. So number 7 and number 3 match up because the arteries are the LAD, the left circ, and the RCA. So we've got that matched. All right. We are doing pretty good. We don't have number 1 matched yet. And we don't have number 8 matched up. Okay. So give me 2 more. Give me some more numbers here. Number 9. All right, let's see what's behind number 9. Normal 12 lead. Woohoo! Normal 12 lead. So number 1 is actually a normal 12 lead. I make sure I found one that has the T waves inverted in AVR and V1, and that all the other T waves were acting appropriately. They were not messing up with us. Okay, so apparently, let's try the last 2 numbers. Go ahead and pick one more. All right, number 10. Number 10, AFib, that matches up with our rhythm. Name the rhythm. That was AFib. And our last one, number 12, was the electrical waves. And that was the one that went with number 5, P wave, PRI, QRS, and T wave. So just this short little game. This was nothing fancy at all. This was just Baby Yoda saying, I know all the EKG stuff now. Because, you know, Baby Yoda is Baby Yoda.
So adorbs. Oh my gosh. That was
So
really
super cute. Super cute, super fast. I told you I was going to do something super fast tonight.
Yeah, no, I think that this was amazing. Hey, KJ. And guys, thanks for playing along with the game. We always love playing with you guys. So, thank you. Let's kick off. Let's first of all thank Michelle because she's literally she's our cheerleader. She's our right arm. She's my sister from another mister, and she's always here for us when we get in trouble as far as needing help with EKGs. So we appreciate you, Michelle, as always. But let's kick off the last session of tonight. Now, first of all, I got to announce the prizes. Last night, we had randomly chosen 2 winners. Marcia, when you hopped on today, I was so glad because you won one of the badges. So all you have to do is just message me your address, not in Zoom, but in Facebook Messenger if possible. And I can get this out to you tomorrow in the mail. This is a cute little badge that has the STEMI equivalents on it and from Scope Education. So very cool. And then Chelsea was our other winner. So Chelsea was on Zoom last night. So Chelsea, hopefully you're here, and make sure to get me you guys' addresses so I can mail out your prizes. Okay. So, oh, you are here, Chelsea. Yes. Okay. So I need your address too. You won. See, it pays to be live. I'm telling you, it pays because these badges are so cute. Okay. So let's go on with our session. So first of all, speaking of winners, so nobody was able to beat KJ this time. Oh, Chelsea, this badge, you're going to love it. You are absolutely going to love it because it shows you the new STEMI equivalents that are in that article that I always talk about. That just got published November 15th, 2022. They're all here. So you're going to love this, Chelsea. So we were looking for, if you remember night 1, oh my gosh, I don't know why I'm coughing. If you remember night 1, I said, hey, here's how to win the scholarship. Lift up your fellow students, cheer them on, help them find things when they get lost, right? That's if you can remember that. And so the person that did it the most this round was KJ. So KJ, you won the scholarship. And the thing is that KJ is a just natural born cheerleader for other people too. She lifts people up and encourages you. And nobody could even come close. So if you ever come to this challenge again, when we hold it, like I gave you guys advice on the first night, watch KJ, watch what KJ does. And she will inspire you like she inspires everybody. And she does this not even knowing, you guys, she's lifting you up. So, once again, congratulations. And she's always there with the answers too, because she's just so smart. So, if she's saying something, she's usually right too. So anyway, congratulations. That gets the winning out of the way for the night. So let's get into the knowledge. Okay. So, here's the thing. We know this, and here's a study that proves it, that the EKG software is incorrect very often, anywhere from 6 to 42% of the time. And we just don't have the wiggle room to be wrong 6 to 42% of the time. And so what our lead coach, EKG coach, David White, he actually taught a class in our study hall today in our 30-day EKG challenge. And he has this saying, and he says, yeah, I trust the software about as much as I trust gas station sushi. So of course we had to put some gas station sushi on the slide. But really, if you think about it like that, it's true. So what can you trust? You can trust your own reading skills. But in order to do that, you have to be able to know what normal is. Now, of course, you can ask the EKG reading German Shepherd, STEMI with Remy. You can ask him. He'll help you interpret the EKG, but usually he's too busy barking at our neighbor dog to help me with EKGs very often. So we just have to learn it ourselves. So a couple of things to know. The T waves are all going to be upright except for two leads, AVR and V1, right? And I got to tell you guys that literally is so important. And I know if you've been hanging around me for any length of time, I know that you guys are probably tired of hearing about me talk about the T wave. But it was a couple days ago that me recognizing a very subtle change in a T wave in a serial EKG that saved a 48-year-old male's life. So I really feel passionate about the T wave situation. And in order to spot them, this is step one. They must be upright except for AVR and V1. This person had biphasic T waves, one that went up and down. That's always ischemia to proven otherwise. And he ended up getting a stent in his LAD. So learning this and taking the time to commit it to memory is critical. Okay. Other things that are critical are recognizing the intervals are important. Now, when I was learning this, I was told, oh yeah, you don't need those numbers on the EKG. They're for the cardiologist. Like I'm making fun of her because that's what my teacher was telling us. And flash forward to when I became a PA and I realized that no, actually everybody needs those numbers because it helps give us clues. Like for example, with Wolff Parkinson's White, which can lead to AFib with RVR or other things, right? If it's a short PR interval, that's a clue you might have Wolff Parkinson's White. If you have a prolonged QT, that can be lethal. We saw, some bad rhythms last night that were lethal. And by the way, if you want to watch the replay, just let us know. We'll get you the link. They're also in the guide section of the Facebook group. But here's the thing. If you don't know the normals, it doesn't print it out for you like the labs do. So it's critical to understand the basics on this. So we'll show you on an EKG. And then we talked about voltage in the terminology of night one and why it was so important. And Jasmine, Michelle or Ruben, can you help with the link to the replay link for Jasmine? And basically the voltage is so important. So I think Michelle will probably copy and paste. Marcia, look at you being helpful. Oh, see, this is what I'm talking about, Marcia. This is what I'm talking about. Okay, anyway, high voltage, we worry about big ventricle. Low voltage, we worry about pericardial effusion. but it can mean other things too that are not as bad as that. And low voltage really is significant. I had a very large pericardial effusion today, and I went back and looked at the EKG, and I was like, oh yeah, this is, I wish I could have saved it for you guys, but the voltage was so low, it was almost flat. And so thank you very much for posting that, Ruben. But basically, this is going to house all the replays, even tonight, just FYI. If you don't know how to spot voltage that's normal, right, then you can't spot this. The machine will usually tell you low voltage, which is good. But what do you do with that information, right? You got to ask about symptoms. Are you short of breath? Is this new for you? Have you had any chest pain? Things like that, right? And high voltage, how much do we worry about that? Well, that depends, right? These are all very loaded questions, because if you have high voltage, potentially you could be dealing with a left ventricular hypertrophy. What are we going to do about that in the clinical setting right now? Really nothing, except for make sure they have good blood pressure control, which they probably don't at home. And then also understanding that the P and the QRS and the T are like a family, and they should all be holding hands. You should never see a T marching off to the next mom, okay? So super, super, super critical to understand these points. Now, the normal EKG, let's talk about the anatomy of the EKG, okay? So as we just talked about, let me just make sure. As we just talked about, you have a mom, a dad, and a baby. And I know that's very simplified terminology, but if you can just remember that, you'll know that the mom shouldn't be as tall as the dad. And if it is, it's probably right atrial enlargement. If you have a T wave that's as big as the dad, well, then you're worrying about ischemia or hyperkalemia. So you really need to kind of commit those to memory. And then you also need to always hunt the T waves, right? Because let's just stick on the T's for a minute. This one's upright. This one's upright. So when they have a heart, that means they're doing good. I'm liking you that you're upright. I'm not liking some other things about you, but you're upright. So I'll give you that. In fact, all the T's are good, right? And then we wanted the AVR and V1 to be inverted. So all of them are good, right? So that part's good, but there's more. In fact, if you look over here at the T wave here, this is a little concerning because it's almost as big as its dad, right? So if that's the case, you always want to look at, going back to night one, contiguous leads, right? Looking over here, that lead is contiguous, also fed by the right coronary artery, as is that. And so this is a little concerning pattern here, that those T waves are potentially what's called hyperacute, okay? So anyway, long story short, the size of the T wave matters, the direction matters, and if they are that big, you have to worry about ischemia as well as hyperkalemia as well. Now, the other thing, as far as just looking at a 12 lead, because they can be kind of intimidating, this is your 12 lead here. So you've got your 12, okay? And then you've got your rhythm strip here. This is usually going to be either lead 2 or V1 pulled out for you to see what the rhythm is. You can tell from last night, they have P's, right? PQRST. And the R to R is normal. So this is a normal, well, it's a sinus Brady, right? It's sinus Brady because the heart rate's 42. So that's an interval that's important. Let's stick with those for a second, okay? So KJ said yesterday, I like when you type on the EKG. Okay, so we're gonna do that. Let's do that, KJ. This is just for you. Let me get my little typing thing here. Okay, actually I'm covering it, aren't I? Let's go over here. Okay, so normal heart rate should be between 60 and 100. We also have the PR should be 120 to 200 milliseconds. Then you've got the QRS. You guys tell me, what's the maximum that can be? Yes, draw your lines, KJ. I know. What's the maximum it could be? Ooh, close, Jasmine. Yes, Okay, 0.12 or 120 milliseconds. Sorry, my typing is not good today. And then the QTC, we want it to be less than 460, QTC 460. And then the last thing is the axis, should be between 0 and 90. So let's move this and let's see if we're right, okay? So here we go. Let's go over here. Actually, ventricular rate, nope. So there's a problem there because it's too slow. PR interval, 156, yep, we're good there. QRS, 90, yep, we're good there. It's under 120. And then the QTC is 388. So we are good to go there. And 45, that's the axis here, is between 0 and 90. So yay. And that's just kind of how you look at it. Now, the last thing I want to show you on here is understanding that you must, as KJ always says, draw your lines. But what the heck are we talking about? If you haven't hung around us for a while, maybe you don't know what we're talking about. So let me just show you. So isoelectric means the line that's the flattest, okay? That's always, you have to know where to trust to line up with so that you can see if there's ST elevation or depression. So that from the end of the T to the beginning of the P, okay? That is the flattest line. When you go over, you can see when you draw, right? You're staying with that isoelectric, clearly if there's ST elevation or depression. Now, just to make it a little bit more, I don't know, distinct. So this is, oh, I don't want to use that. I want to use something else. Oh yeah, maybe this. Okay, right here, that's what you're looking at. Okay, you're looking at the ST segment to see if there's elevation or depression. So right there, that line right there. Okay, and you're going to do that on every part of your EKG. So hopefully this was helpful in kind of breaking it down. And last but not leastly, on this slide before we leave, it's always important just to understand, I'm just going to put a concept together for you real quick about the conduction system. So if you go over here, who's this? Who's this guy right here? What's his name? SA, good. He sends the impulse down the intranodal pathways and going on down to what node here? What's this guy here? He is the AV. And then we're going to slide on down the bundles at the same time. I just can't draw the same. Okay, cool. And then the ventricles, right? They're going to depolarize. They're going to squeeze their blood out and everybody's going to be happy. And there's a couple things to know. We talked about this a little bit yesterday, but if an impulse is coming from the top of the heart, it's going to be narrow. If it comes from the bottom, it's going to be wide. Okay. So that's pretty critical to understand. But we kind of talked about that with rhythms yesterday. So that shouldn't be new information. And then just looking at a normal EKG for a second, this one is pretty close. The only thing I don't like about this is what's happening in lead 3. There's a little bit of artifact in lead 3. But here's the question that you got to ask yourself if you have artifact. You got to ask yourself, is it enough for me to get another EKG? There's only really 2 times for me that I would do that. Now, one would be if I couldn't see a P wave, right? I can see a happy, beautiful P wave in lead 1 and lead 2. And if I was potentially thinking that this was AFib right here, I would repeat the EKG, but also if I couldn't adequately see the ST segments, but I can. So a little bit of artifact, if you can see everything you need to see, is acceptable. If you can get a cleaner EKG, get a cleaner EKG, but sometimes you can't. And then, of course, just showing you all the T waves are upright like they should be, looking at that line, right? Looking for the ST segment elevation and depression. So this meets all the criteria that we just covered in the intervals. And of course, always knowing that when you have normal axis, your 1, 2, and 3 are going to be up. Now, if axis and bundles are things that scare you, and I know that a lot of people feel scared by both of those things because not only do you guys tell me this all the time, I also felt the same way. I literally never understood either. Or honestly, access why it was important. But if these are things that are scary you, we have a very easy way to remember them. We teach it to you in our EKG workshop that we do in our 30-day EKG challenge, and we can easily put your mind at ease. But this EKG is normal. Okay, so that's good. Now, here's Michelle again. I mean, she's just like, she's all over it with her visual aids. I got to tell you, this is nothing. She's got a heart on a stick. She's got electrodes that she puts on her own self to show you what each lead is looking at. So if you're a visual person, you want to hang around Michelle. Okay, this is a quick 10-step system, and there's also room if you want to take in your workbook and write this down to practice. And I would do that so that you sort of start to memorize it. But if you don't want to memorize this, and nowadays we don't have to, we can easily pull out our phone, right? We can have a picture of it and look at our phone. But basically, let me just run you through this really quick, how this looks. Okay, so first of all, if you have somebody who is big sick, little sick, let's talk about that for a second, because I realized that that's totally a paramedic thing. When I first started teaching this class, like when I'm 4 years ago now or something, it was 4 years probably. I said that term, and people a couple times in a row were like, yeah, we don't really understand what you're talking about. They were brave enough to tell me that. And so I kind of equated it to a patient, because if you walk in and your patient is, oh, that's okay, Chelsea, no worries. Worries at all. If your patient is pale, cool, and diaphoretic, and they're slumped against the wall, right? Like you walk into their room and they're just like, that's big sick. You're gonna not pass go, collect 200. You're gonna do something right now about that patient and take care of it. And it's the same thing with the EKG. If you have a STEMI, or if you have an asystole, or if you have a VT or a VFib, you're going to just treat that, and you're not going to go down and analyze the cues, right? You're going to be like, what's your cues? I don't want to talk to you about your cues. We got to get you to the cath lab, right? So anyway, that's big sick. Now, little sick, there's lots of stuff in between, to be honest, but little sick is when you have a second to like keep looking at the EKG and, the patient's stable enough. Now, the next line down is looking at the rate, because you want to make sure they're not too fast, they're not too slow. The rate should be between 60 and 100. Then you're going to look at the rhythm, analyzing, seeing what it is. Again, you can watch the rhythm section last night to practice, but essentially we're asking those questions, right? Does it have a P? And you're asking, is it regular or irregular? All those things. Fast, slow, wide, narrow, and it'll help tell you what the rhythm is. And then you're looking at the intervals, which includes the axis, and then you're looking at those ST segments. As KJ says, you're drawing those lines to see if there's elevation or depression. And if there is, then you're going to stop and you're going to analyze it, because if the machine didn't flag STEMI, but you see an elevation, you got to figure out why. Now, sometimes that can be from pericarditis, but sometimes it can be a STEMI that the machine missed. The machine is not perfect. We already know that, right? And so it just may be ST elevation that's not yet meeting criteria, but it's there and you're nervous about it. So you could always do redo the EKG, a serial EKG, and look for changes. We had a person we recently did an EKG on, and a couple minutes later, they already had changes. They went straight to the cath lab. Because remember, dynamic changes are never anything to mess around with. Can you do this in an urgent care? Can you do this in a primary care? A lot of people say, well, why would you? Okay, good question. Because if you have a patient who you think you're nervous about for whatever reason, their chest pain description, their history, maybe their EKG looks a little funky to you, but you're not real sure, then you could say, okay, I want you to go to the ER. And they're going to say, no, I'm not going to the ER, right? Because that's what happens. So you guys know. And then you could say, okay, well, what if we just have you sit tight for 5-10 minutes here? And if you don't mind, I'll just leave all these stickies on you and we'll just redo and see where you are. And let's just make sure that nothing's evolving or changing. Does that sound reasonable? And most people are like, yes. Do you always have the room to do that? No, but it's helpful. So Yeah, and KJ's talking about an NSTEMI. Yeah, and STEMIs will not present as STEMIs, right? But they will sometimes give you other EKG clues that are not ST elevation. That's where the biphasic T waves come in. That's where the hyperacute T waves, all the things. And so then if it's not a STEMI, then you can keep going, looking at the hypertrophy. Is it too big, too small? Looking at the voltage, right? And then analyzing the T waves. Are they all up? And then inverted in AVR and V1. And then do you have Q waves? If so, where are they? If so, are they contiguous? If so, are they pathologic? How do you know that? We talked about that on night 1, where it'll be at least a third the height of the R wave. But Q waves can also come in other times, other conditions. They're not always just from MI. You can have them in PE. You can have them in hypertrophic obstructive cardiomyopathy. So we are always taught like just part of the story with acute. But I digress. Now, the last thing you're going to do is put on your chief complaint-based glasses. I used to have glasses, but since we moved, I don't know where they are. But what you do is you go back into the EKG with your glasses on, and you're looking specifically at their EKG for certain things. So if you have someone who comes in with syncope, then you got to look for several things. You got to look for a prolonged QT. They could be going in and out of torsades. You got to look for a short PR. They could have Wolff Parkinson's White. You got to look for a hokum. You got to look for Brugada. And then you got to document that you didn't see any of those things, because if they had one of those things and you missed it and they went home and had a bad outcome, then that's bad. So that's why I made this last step, to remind myself to go look for the high risk things that are associated with that chief complaint. You'd also look for pauses. You would also look for super Brady, and you would, act accordingly. So that's kind of the 10 step. And you can use that on any of your EKGs when you're learning, and you can practice it. It will encompass everything you need to keep you safe. Now, let's talk about some other EKGs. Okay, let's do it, because this one I got recently, and I was so excited because I was like, oh, this is so juicy. People were laughing at me today at work. They're like, you're such a geek. I'm like, I know. And I just, yes, I am. But anyway, let's talk about it. So do you see anything that is concerning? Anything at all that's concerning? All right. Okay. Marcia says QT a little long. It is, it is over in the uncorrected. But when it's corrected, it's 463. So it's not really that prolonged. I mean, it is for uncorrected, but you don't use that number. So the machine, we don't, it's not too long yet, basically. We would, and if you had any questions, you would measure it yourself. You could use that little tool that we give you in your kits. The PR is long. Exactly. Now, that begs the question, as Chelsea says, is this potentially a third degree block? And that was my question, Chelsea. So I applaud your eagle eyes there, multitasking at work. And if you look here, you've got a P, 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 P. Okay. So, I'm thinking, I thought this was just a first degree block. I did run it by my doc too. But it's one of the longest PR intervals that I've ever seen, 338. And, they say that, and yes, they are married, exactly, KJ. I always talk about that. But they say that, first degree blocks don't really cause anything. They don't cause your syncope. They're not your problem. But there's other things going on in the CKG. Okay. Now, first of all, I would wonder why they're so long. Are they on flecainide? Are they, what's happening? Are they on an antiarrhythmic drug? I'd look at that. And also they're Brady. And so what would you ask the patient? What would you ask them? Yeah. Oh, good. Good eye. Good eye. Potentially hyperacute. Yes. You'd ask them meds. Absolutely. But also the most important question. Yes. Also athlete. Yes. How do you feel? Matt, how do you feel? Because It could feel fine. I had a patient this week with a heart rate of 30 who felt fine. So patients can feel okay. And we need, in order to do something about it, like pacemaker wise, they need to have symptoms. They need to have symptomatic bradycardia that's non-reversible. And then also one thing that's going on here is it's telling you there's non-specific T wave abnormality. Now, sometimes when it thinks the QT is prolonged, it will also say that, okay? And it'll also say non-specific ST wave changes a lot too. And when it says that, you should worry. And the reason why is because there's a lot of bad things that can hide in non-specific changes that need to actually go to the ER or the cath lab that we need to be concerned about. So this is most likely just due to the QTC that's thinking it's too long. But overall with this patient, we should be concerned with the whole totality of the situation. And this is a bradycardia due to, developing ACS. So these are all things to consider. Now, remembering that what STEMI with Remy, okay, he had to come on the slide, and he wants us to remember that contiguous leads are fed by the same artery, like 2-3 and AVF, and then reciprocal changes are the opposite. And yes, Remy is hunting for STEMIs. He's always hunting. Okay, so what I want to share with you is this nice little graphic. I love his ears too. Everybody loves his ears. So I wanted to share this graphic with you because here's this is the info. Go online, look it up. This is the chart that's just there waiting for you. Okay. When I saw this, I was like, and I kind of had that like brain freeze moment, when you eat too much ice cream. And I don't know, it just was really not helpful for me. And so anyway, long story short, I ended up taking this and scrapping it. I mean, the data's there, but I scrapped it. And then ended up doing something different. And I made a color-coded chart. And that was easier for my visual eyes. But that's something that we do in our workshop because we're visual learners in our workshop. And everything we do is always going to be visual. So if that chart works for you and you can reference it and understand it, great. But otherwise, you can come to it our way, which is the visual way. All right, let's do this EKG because we're going to use contiguous and reciprocal for this EKG. I'm guaranteed. But I want to ask you guys something. Would you, just hearing what you're hearing here, when you hear this, do you have concern? Would you almost not even care what the EKG said and send this patient to the ER if they came to your clinic? And the answer to that is, I'm hoping in the chat, going to be yes. Okay, yay. Okay, you guys are finally playing with me. I love it. Okay, so on here, he says, it feels like my last MI. Oh my gosh, right? Yes, Matt, you can't. Yes, Matt. He has 7 out of 10. It's lightheaded. It goes to the jaw, back, left arm, and all the things, right? And this, if they ever say it happens when I'm lifting, then that's basically that's exertional chest pain. And exertional chest pain, I always put it, KJ, is never good. Okay. So what are your differentials? Remy said, this is puppy Remy. He says, what do you think is happening? Well, I'll tell you what I think is happening. He needs to go to the ER and go to the cath lab. Yeah, ACS. Could it be low blood pressure? Could it be a AAA? It absolutely could be a AAA. Absolutely could be. And we need to think about that before we just send him to the cath lab. And a lot of times we forget that. I had a good friend of mine recently remind me of a case he had, and I'm going to share it with you because I want it to really stick. Okay. Because when you're a hammer, everything looks like a nail, right? And when I say that, I mean, I'm a cardiology PA. Everything is going to be a STEMI when they're chest pain, right? But we got to think about the non-STEMI things. And it's hard to keep them in like anywhere in our brain when we're in cardiology. It just is. But he said, Jen, I had this guy, he came in, he was in his 40s. He had his kids with him. And he said, all I saw was elevation in AVR. And he said, I saw a little bit of depression in the other leads. And he said, I went to examine him because that's not a STEMI. It's not. It's now on the list of things that we would urgently take to cath lab according to the new guidelines. But he said, when I was looking at him and talking to him, he kept doing this. STEMIs don't usually do a lot of movement. STEMIs are usually fairly still and quiet, and they're not moving a whole lot. But kidney stones, they move a lot, right? So do AAAs, dissecting aortic aneurysm. And he said, I asked the guy, like, describe your pain. Oh, it's heavy, tight, right? But it goes to my back. Well, when did this come on? Gradually? All of a sudden. There you go. Red flag. So what happened is they said, let's get a quick CAT scan. They found a massive dissecting aortic aneurysm. They rushed him to the OR, opened him up to try to repair him, and he was dead. So he said when they did the autopsy, what happened was the part that was dissecting was feeding the left main. And that's why his EKG looked like it did. And so we always have to keep those kind of things in mind. But the red flags were the sudden. Some people say ripping, tearing. Some people also have very high blood pressures in this situation. But at the end of the day, we have to think about other things other than STEMI. Yes. Had that happen from cath lab to CT, dissected but lived. Yay, love those stories. Love those stories. So here's his EKG. What do you guys think? What do you guys think? It's because bad things. You think bad things. I agree. KJ, you haven't told me to draw my lines. I was just here. Oh, there we go. I was just here running amok, not drawing my lines because KJ didn't tell me what to do. One in AVL. Yep. A lot going on, Jasmine. Exactly. Okay, let's break it down. So first of all, this is clear with the naked eye, right? This is, as KJ said. Oh, I didn't even draw this one. Sorry. Oops. This is an acute MI because we have 2 up and 2 down, right? 2 up and 2 down. I love your little graphics, Marsha. Those are so cute. So yes, ambulance if we're in the clinic, if we're in the ER, they're going to the cath lab. But basically, if you think about it, 2, 3, and F are contiguous, right? You have to have 2 contiguous leads with more than 1 millimeter ST elevation, and then 2 leads of reciprocal change. So your 2 leads are, according to your chart, 1 AVL and V2. You actually have 3 and 3. So this patient is going to most likely have an RCA lesion. And yeah, he might even have some rate related issues. He might even have some right ventricular involvement because the ST elevation in lead 3 is bigger than in lead 2. So yeah, this is easy, right? Now this is not so easy. I'm going to tell you that I know that when you see weak come in, you're like, oh my gosh, really? Right? And you're like, but really, you're weak? I actually love the weak chief complaint, but nobody likes weak or dizzy. But I love the weak complaint because I'm like, oh, I get to think about so many differentials. And so, of course, we're going to get an EKG. That's just like SOP, standard operating procedure. But yeah, I hate dizzy. I know. I like weak better than dizzy, though. I would pick weak every single day of the week because, like, get a CBC, look for anemia, CMP, look for high potassium, look for renal failure, consider a stool guaiac if they have low hemoglobin. You're looking at the EKG for ST elevation or any other subtle, OMI, occlusion MI signs. You're looking for bradycardia. You're looking for pauses. You're looking for AFib, like so many things. You could also consider, if he has signs of fluid overload, you could consider, adding on a BNP. You could also think about a thyroid. So like there's so many things to think about. And sorry to go on the non-EKG tangent for a minute, but week is just so fun. I love to talk about it. So anyway, let's get back to our guy. he's going to get an EKG before we do anything else, because that's what's going to happen the fastest. And lo and behold, what the machine says is what I was just telling you guys, right? I was like, hey, if you see this, it's not good, right? ST abnormality. Okay. Now, let's look at this EKG. And I'm not even going to draw my lines, KJ. I'm not even going to do that. I want you guys to think about, settle this in your mind. It does look a little bit flutterish. It wasn't. It does look flutterish. So I see what you're saying. But I know, just for now, tell me, and or don't tell me, but commit in your mind, what would you do if you saw this? What would you do? You're in the clinic, let's just say. Patient has marked ST abnormality. And he's weak. Does anybody have any thoughts? And if you don't want to share because you're shy, that's okay. Consult with cardiology, that's not a bad idea. They call 911, Jasmine says. Ooh, Jasmine, tell me more. Tell me more, tell me more. Why are we calling 911? Oh my gosh. Matt for the win. Actually, let's do a combo. Let's do an assist from Jasmine, because Jasmine wanted to call 911. So yes, possible posterior occlusion. Yes. And we could confirm it by doing a V7, V8, and V9, right? And look for just 0.5 millimeters of ST elevation. But at the end of the day, this can go straight to the cath lab. And nowhere on here does it say STEMI. This is also one of the things that's in that article that they said, hey, this is the STEMI equivalent. No, it's not. It's actually a STEMI, but anyway, whatever, semantics. But we just need to be able to pick it up, and we need to be able to get it to where they need to go, because time is muscle. So you don't want to delay on this one. You want to be like, oh my gosh, depression. Okay. Now, this is an interesting concept, because if you think about it, you're seeing depression here. The opposite must be on the other side of the heart, right? The elevation must be back here. So you're always thinking about the heart as a 3D object, and that's what you were seeing, okay? All right, so the take-home points of tonight. The president should always run the heart. The president is sinus node. Don't trust the EKG interpretation. Always remember the EKG family should be holding hands. Memorize your intervals, and always, as KJ says, draw your lines. So I did throw this in for workbook purposes for you to practice. I didn't want to go over it tonight because I want you to practice it. And then if you want the answers, they're in night 3 in the guides. I'm going to skip over that. This is for you to, yes, babies don't get depressed. This is for you to practice in your workbook, writing all the things down if you wanted to. And you just really quickly go through and write them down. And then there's also a place for you to practice drawing your conduction, practicing on an EKG, looking at those T waves. And that is it for our 3-day EKG challenge tonight. And we have enjoyed spending the last 3 nights with you, engaging with you, hearing all your answers. Yes, I know, it's so fun. The good thing, though, is that if you stick around, I'm going to tell you just a little bit about our 30-day EKG challenge, because if anybody is like Jasmine and they want to learn more, we have this program starting on Monday. And inside of it, you could see here, Michelle is using her visuals, always using the visuals. And inside of it, we have a bunch of things lined up for you. So Monday, we're going to do the welcome call, show you around, do a little deeper dive on EKG terminology, kind of like expand on what we learned on the first night. And then we're going to do some more arrhythmias with our wonderful, wonderful paramedic, Sean. He does usually like a multimedia event. And then I'm going to do the basic 12-lead intro. So more than what we did tonight, we're going to go crazy on it, right? And then we have a bonus class with Coach Michelle. She's going to do, we have like guest lecturers that come in or special topics every month, because people stay in this group for years. Actually, you get 6 months when you sign up for our program, but people end up renewing and staying. because they're like, oh yeah, the topics are changing. I want to see what comes next. So Michelle's doing hemodynamics and vasoactive drugs, which is going to be amazing. And then on the 11th, we're going to spend 2.5 hours doing hands-on workshops. And so that's actually KJ's putting in the comments. David's study hall. David's study hall is amazing. In fact, he had study hall today. I sent him a couple EKGs myself so he could put them in your class. So if you get into the 30-day and you want to watch those today, he covered some STEMI stuff that was like mind blowing. But he actually is on another level. But you can send your EKGs and he'll break them down for you on the class. And he does it every other week. So it's super fun. And then this one, we use the stuff I send you in the box. We then have Sean coming back to give you the arrhythmias, but then test you on them. And then more study hall with David. I'm going to do an AFib primer. I'm going to do chief complaints and how to work them up, which is going to be so fun. So fun. We're going to do all the things. And then putting it all together, this is going to be where we're going to practice all of our basic EKG knowledge. And then David has another study hall. Now, that's going to be just May. This runs all year, so we have more stuff. But the biggest thing I think is the 3-hour workshop. This is Michelle and I, when we taught live, having a really big EKG, looking for non-specific ST wave changes. This EKG does have them. By the way, I wish all the EKGs were as big as this. But here's the thing. So when you join us in the 30-day EKG challenge, you not only get access to the live classes I just showed you, and they're all recorded, but you get access to everything we've done in the past 3 years. And I just had Ruben, our wonderful assistant, make a course catalog. So you could look through. This is like not even an iota of what's in there. Okay. But you get access to all the recordings. You can binge watch whatever you want. And you get a learning portal where your CE classes are. And this is probably one of the best times to get in this challenge because we're about to switch actually CEs. So if you could get your evaluation in by the end of May, you get these 12 hours, but then you'll get another different 15 hours. So you'll actually get like a ton of hours just by joining at the right time. So you get 6 months with us, and yes, you get all the things. But this time, we're actually adding on something else. You're getting everything in the box, which includes the tool, so you can help with your lines, but we're also sending you a cute little binder so that you can print out notes that are in the Facebook group and keep them for reference in a nice EKG binder that we designed. So that also comes along with the EKG kit. And then you have your learning portal here. And then this is one of the workbooks we send you. We send you crayons. We send you all the things. This is one of our members, Alice, who really enjoyed hanging out with us in our 30-day. In fact, she's still in. See, she's got her stuff all studying here. We love having her in a group, but she really felt like it helped her get a grasp on EKGs. And so if you want to join us, the rates are here. It's an excellent deal for students and for EMS. And even if you join at the student rate, if you don't need CE, you still get all the goodies. They get mailed out to you. And you get the CE if you join at EMS, RN, or NPPA. And so this is all the things that you get, right? And the price ranges anywhere from $149 to $299. You get lots of guest speakers that have been speaking for the last 3 years, access to all their stuff, the welcome kit, the 12 hours, live weekly classes, multiple classes a week that you can go to, the hands-on workshop, and then study halls with David. So it's really a good program to help you get comfortable. And you also can ask questions in between classes. Yeah, it's a good smoking deal. But you can ask questions between classes and we will answer them. So you kind of get this hybrid class where you've got all the recordings, but you also have live stuff. And then you have, when we're live, you can ask us questions of any of us coaches, and we help you. So you get that live support too. Oh yeah, it's really, really good. Now here's that course catalog. I broke it down. I think there's some classes from Michelle that I still need to add on here. We do this usually every other month now. I think we're on every other month. for the 30-day, but it goes continuously because we have people that are year-long members or even lifetime members. So we keep things spicy for them. We keep it fresh. But anyway, here's just some of the lectures I've done in here with descriptions. And then there's the, I've done cardiac murmurs with actual sounds, more patient scenario, what's hot and what's not in cardiology, a documentation workshop, chest pain red flags, young people that had disease, how to do a good cardiac consult in the office. So this is good for a new provider too. And then we have tons of guests. So we've had Think Like a Pacemaker, which was taught by wonderful Sean, different Sean. We had a whole deep dive on antiarrhythmics. We had a national expert. Actually, she's now a world expert. She travels all over the world. She did a talk on lipids in our group for us. I still to this day do not know how we landed her. It was connections, but she literally charges like $10,000 an hour to speak. So she did a lecture in our group. Jen Bush with Chart Healthcare, she came in and did a PVC localization workshop for us. We had Jen Lewis do POTS. We had Aaron Lee do long haul COVID. We had Mike Sharma up here. He's also a national lecturer covering chest pain guidelines update. We had Aaron. She talked us through the life of a EPPA, but she also did a great lecture recently on devices. Yeah, this catalog is really cool. She did a whole thing on devices. Michelle has way more lectures than this, but the thing I didn't tell you is you actually get access to the EKG Launchpad group, which just has beginning lectures. So there's a ton of stuff in there by Michelle where she talks about, she does a bunch of drawing classes about the coronary anatomy, inside the heart, outside the heart. But she does a ton of classes. She even does more advanced stuff like LVAD and vasoactive drugs. And so that's amazing. And then we have we call her our cardio queen, Megan. She did a lot of classes for us. This is a good one if you get in the 30-day. This one is like so good. It tells you all about the good cardiac apps. She talks about diuretics, what to do when changing. She did a deep dive on the SGLT2 inhibitors. She talks about how to interpret stress tests, how to order them, how to choose, risk stratification, cardiac enzymes, like all the things. And then we have a wonderful, I mean, I know this just keeps going, but like, I'm telling you, this is some good stuff in here. We have all of the sleep apnea and pulmonary hypertension stuff that you could want is in here with our sleep queen, Carissa. And then David has all sorts of study halls. This is like a fraction of what he's done. He did something on pacemakers, STEMI mimics, AVNRT, axis review, U waves, AV block review, Brugada, LAD lesions, lethal arrhythmias, R-wave progression, like literally he's done it all. Okay. If you want a topic, he's probably already done it. And then here's Sean. He's the one that's going to do our rhythm ones this May. And he talks about heart blocks multiple times. You got lots of heart block practice with him, but he even did a little ACLS prep course and he's done a med math class for us. So he is like the man and we love having him around too. And then we actually had a bunch of lipid lectures with a lipid specialist, NP, Whitney. She talks about how to get, some of the agents covered, what basic and advanced testing looks like. And she's just thebomb.com. And we also had a bunch of lectures. I know, isn't this amazing? Like when we finally sat down and put this together, I was like, this is a lot of knowledge in this group. And people you could go and access like any one of them right now. They're all recorded already. So Kim was an EPPA. She's transitioned to do valves now, but she talks about everything anticoagulation, all the drugs. She even does cases. She talks about the Watchman. She talks about atrial appendage ligation. She talks about the antiarrhythmics. This is such a good lecture. But yeah, you really just want to take advantage. And then we had some fun. So Camille is kind of like our, I don't know, she's kind of our random stuff lecturer. So she loves the gaming as well. So she did a left heart cath game. She walked us through what a left and right heart cath looks like with actual images. She's done a talk on PAD, and also if you ever take call for cardiology, she does basically a whole thing on how to navigate that. So basically, we start Monday. when you're in my world with all of my friends, I call them my friends because they're my friends, that are both coaches, but also we have a lot of members who lift you up. You get supported and you get confident, and it is a magical thing. So 6 months bathing in that, right? And getting access to just soak up whatever topics interest you is so fun. And then you can ask real life questions. What other program is doing that? Right? So tonight's prize we already gave away earlier, but I did want to stay and let you ask questions if you have any about either the 30-day. If you had questions about the kit, I have the binder here. I also have the little kit. And this all, we put it in a big box that gets shipped out to you. Comes with, and I think I showed you this night one because somebody won one of these, but there comes a little mini painting. You can probably see paint on my nails because I was painting some of these earlier. We send you this tool, which is so nice to have. So you can see if there's ST elevation. We send you crayons to color code in our workshop, red, green, and blue. There's a workbook in here, and there's normal sinus EKG. There's a couple other things, and a cheat sheet, which I will not show because it is just for our students. But it has all the good stuff, an access chart, and some other cool things. So we can't wait to see you inside. There's looks like links everywhere. Thank you, Ruben and Michelle. But it is sort of addictive. So just a little quick story before we end. And it's been just so fun hanging out with you and getting to know you guys. But Michelle actually came through this challenge, I think like 3.5 years ago. She was a student. And it was one of the first times that we did one of these, the binders. We don't always do the binders. So we're probably going to stop doing them really soon. But so she got her kit and she has this like beautiful kitchen counter. And she set up like a bowl of fruit and she set up her binder. She had all her markers out. She had her box ready and she took a picture. I'll just never forget it. And she took a picture and she's like, "Who's ready for class?" And I was like, I'm a fan of this girl. I need to reach out. And so that formed obviously a fast friendship. But then I realized her experience and her love of teaching. And now she is like the glue in our group and she makes everything fun. And it turns out that she was just so talented. And who knew? And that's how all of our coaches have come to us. Everybody started in the challenge as a student. It was just me. But then I found all these amazing people. So Michelle, do you have anything you want to add for these young folks that are staying on this?
No, I think the thing that I always think of is, first of all, that I absolutely still love, even after 4 years, I love the actual 30 EKGs. And I know I keep saying that every time, but I love them. Jennifer and David took pictures over the EKG and they're walking through that EKG in a very simple manner. I just absolutely love that. And I don't know how many times I printed that out and made new notebooks every single time for probably 5 or 6 challenges in a row. And so that's my favorite. I have to always mention that one. And the fact that everybody just is so encouraging. It's just all about learning, and it's not about, no, that's not the right answer. It's about, let's make sure that we understand it. And why do you think it's that way? Because we don't know it, we're learning. We're always learning. I mean, the whole world is learning all the time. So yeah.
Yeah, Michelle, and I just got it. So this is literally, guys, when I was learning EKGs, I felt like I was hazed. And I vowed if I ever learned it, I was going to do something like this where we would show people it doesn't have to be like that. So if you're wondering, like, why did I just work a 10-hour shift today? Been up since 4 a.m. Why do I do this challenge? And why does Michelle do it? Because we want, for anybody who wants to come, we want to show you it doesn't have to be that way. It really doesn't. And they are intimidating, Jasmine, but they don't have to be. It's literally having the right tools, the right style of learning for you, right? Maybe you're a visual learner, or maybe you're a combo learner where you do it hands-on. But I just knew it was not for me learning out of a book. I'm not a book learner. Okay. Yes, exactly, Chelsea. Oh, you probably, oh, I like you already, Chelsea. And you too, Jasmine. I can tell you guys are good people. Okay, like Hotel California. So anyway, guys, we're gonna let you go, but if you have questions over the weekend, let us know. You can message me in Facebook Messenger and we'll put the replay up on the link. You can watch this, but 30-day, we're starting on Monday. If you want to come with us, hop in so I can get these kits mailed out to you because sometimes the mail takes a little bit longer than I'd like. Now I'm in my new state. Not too happy with the postal service here. But anyway, cool. Yeah, Chelsea, we're looking forward to having you. You will not regret it. Promise, promise. All right, guys. We'll see you soon. And yes, KJ and Matt, Chelsea you'll be fast friends with them too. So when you come inside, it's gonna be a good fit for you, Chelsea. Okay, we'll see you soon, guys, in the 30 next week. And it's been fun. Good night, Rochelle. Good night, Matt,
Bye.
KJ. Good night, everybody live.